In this video, we'll describe an ex-vivo liver resection done for a focal nodular hyperplasia. Here's a coronal CT scan of a young lady who had an FNH that was occupying the majority of the left lobe of the liver and spanning the three hepatic veins with significant intrinsic compression of the right hepatic vein. And because of this sort of anatomic position, this would have been a challenging in situ case. We felt that it would be appropriate to proceed with an ex-vivo technique. We did a midline laparotomy incision. And here's some intraoperative ultrasound footage showing it compressing against the left portal pedicle and the right hepatic vein. Here we are mobilizing the triangular ligament of the liver. We're working our way up to the right hepatic vein here. Here we are mobilizing the liver off the bare area and the retroperitoneum, working towards the inferior vena cava. Here we are working more delicately again along the right hepatic vein, really ensuring that we have plenty of length for our reimplantation. Now we're working on the left side, getting around the confluence of the left and middle hepatic veins, passing a right angle clamp. And then bringing some umbilical tape in. This is us taking down ligamentum aurantius to really clearly see that origin of the left hepatic vein. We'd skeletonize the hilum by taking out some lymph nodes. Here we have the bile duct clipped, making sure we've got plenty of length and we're far enough distal below the confluence. You can see the portal vein and the hepatic artery. We are clamping the portal vein. Here comes our distal clamp. And again, we want to really make sure that we have plenty of length for this portal vein reconstruction. We are clamping the hepatic artery. She had a very generous sized hepatic artery, given her sort of young age. It's a very healthy vessel. Again, making sure that we have plenty of length here. The hilum dissected, we're now going to take our hepatic veins. This is our previously dissected confluence of the left and the middle hepatic veins. We're taking it with a stapler. And then we're going to roll the liver. We'll see the right hepatic vein, which we're just going to do a little more dissection of. You can see it really nicely inserting into the vena cava. We're feeding the stapler in here, snugging this up against the IVC. Lots of length, really nice cut. We then did a mesocaval shunt, in which the portal vein is sewn to the vena cava in an end-to-side fashion. And there's our margin of portal vein. Here we are placing some traction sutures. This allows the bowel to drain intraoperatively, prevents the patient from getting a lactic acidosis, congesting the bowel, decreases the risk of ileus postoperatively. We are opening up our venotomy with some pot scissors, placing some additional traction sutures in. And there's our final mesocaval shunt. Taking off the clamp, nice and hemostatic. Now the liver's on ice, it's been completely removed, and we had a predetermined transection line done intraoperatively with the help of ultrasound. And so here we are marching through the anterior surface of the liver using the CUSA ligature for energy device. This is us taking the lesion off of the parenchyma in a really delicate, sort of tight margin. Since it's an FNH, we can sort of work right up against it. Here we are starting to dissect the FNH away from the pedicle structures. Again, we roll the liver, working sort of distally here on the anterior margin. Now we flip the liver upside down and we're looking at the hilum, and we're beginning to take some of these little bile radicals that are going into the left pedicle. Again, we're hugging right up against that. pedicle so we can have plenty of length to make sure that we're not inadvertently catching any right-sided structures. Staying right on the anterior surface of the left pedicle. Skeletonizing all of its segmental branches. And here we are actually putting a Leland-Jones across the left pedicle and then testing our right-sided portal vein, artery, and bile duct to make sure that we didn't inadvertently catch the anterior sector or the posterior sector from the right side. We're going up the hepatic artery, goes nicely into the right side. We can feel it. And here's our bile duct, just tiny little bile duct. No surprise, since she didn't have any extra hepatic obstruction that led to biliary duct dilation. Okay, and so now we're going to take the left pedicle with the stapler. And that concludes the resection. Here's our specimen with the left lobe of the liver and the FNH. See the lesion from a different vantage point there. Here's the liver coming back into the fields. And then we start our reimplantation with our hepatic vein anastomosis in an endoside fashion to the vena cava. Putting in some traction sutures here. Sewing the back wall of the anastomosis. And then completing the front row. Take the clamp off here. Here we put a clamp on and then take off our IVC clamp just to ensure that this is a nice hemostatic reconstruction. And then we take down our music-cable shunt. Again, snugging up against the vena cava so that we have plenty of portal vein length. And then we do our portal vein reconstruction in a similar fashion. This is end to end. Here we are sewing the back wall and then putting in the final stitch in the anterior wall. Here's our hepatic artery. This was a very healthy artery. No evidence of atherosclerosis or any abnormalities whatsoever given this patient's young age. It's a very fine and delicate vessel. Here's our final stitch on the anterior wall. And then we can begin working on our bile duct, which was tiny and tissue paper-like, totally healthy, non-obstructed, young patient. This anastomosis is done with interrupted sutures. Here it is coming together, tension-free fashion. It's completing the anterior wall, the final sort of 12 o'clock stitch. And we did leave a drain postoperatively. This patient did not have a bile leak and left the hospital on postoperative day number 5 and is doing well and actually had her second child just recently.